Okay, hello everybody. Welcome to the Friends of MSF Edmonton Speaker Series first episode. I am Daniel. I'm a fourth year Bachelor of Science in Kinesiology student at the University of Alberta, and I'm also the VP Events for Friends of MSF.
And I'm Christian. I'm a third year biological sciences student, and I'm the vice president internal at Friends of MSF Alberta.
So, our goal with this speaker series is to bring on guests who are working with COVID-19 or with Doctors Without Borders around the world and to kind of give some insight as to what's going on and to educate us. So, hopefully, this is available on the internet for a long time and people can come back and view this and learn more from the guests that we brought on. And for today, we have Camille Klassen, and you can introduce yourself.
All right. Hi. Just wanted to say thank you to Christian and Daniel for having me. So, yes, I just returned from an emergency medical mission in Honduras, treating patients with COVID-19. So, I'm a registered nurse. I completed my Bachelor's of Science in Nursing in 2007 from the University of Alberta. And one of the reasons that I went into nursing is that I wanted to do travel nursing, and I was always really interested in working with Doctors Without Borders, but I don't think at the time I really realized how much work it took to work for them or how much experience it took. However, so I completed my bachelor's. I started working at the University of Alberta Hospital. I worked at the Nuns Hospital for a few years as well. And then I started doing some travel nursing. So I worked in California for a bit and in Australia for a year. And specialized mostly in anesthetic nursing. I still wanted to do more work working in developing countries, and just working more remote places as well. So I ended up getting the opportunity to work in Antarctica in a really small hospital setting, which mostly you see clinic type cases and emergency. And I was managing that hospital for about 6 months. After that, I applied for Doctors Without Borders and got in. Although it did take me, it wasn't my first time applying for Doctors Without Borders, but this time with my management experience working in Antarctica, as well as I had finished a diploma in tropical nursing from the Liverpool School of Tropical Medicine. So I ended up getting placed in sub-Saharan Nigeria in a very, very small town called Anka, where I was managing a pediatric hospital. And so that was back in 2017. I recently completed my master's in public health from the London School of Hygiene and Tropical Medicine. And so I was actually in London when COVID broke out and ended up coming back home to Canada. And I actually still had a job in California. So I made my way back to California eventually after like quarantining in Canada and everything. Got to the US, and basically where I was in California, which is the San Francisco Bay Area, there was very few cases of COVID at the time, but the hospitals were quite empty because patients were scared to come to the hospital. As well as the fact that a lot of surgeries and elective procedures had been canceled. So I kind of took it as an opportunity to see if I could work with Doctors Without Borders again, and I ended up getting placed in Honduras. So I was just there for 3 months.
Yeah, and so we're super excited to have you. So we want to give a little bit of context about what's going on in Honduras right now. About late October, early November, they got hit with a Category 4 hurricane, Hurricane Eta. And so that was displacing a lot of people from their homes, hundreds of thousands. And immediately following that, Hurricane Iota, which is still going on. Already COVID-19, and you'll be talking about it, has put their economy at a recession, people out of their homes. And then this happens. We'll maybe talk about that after again, about the implications of the hurricanes and how people being displaced and put into tight quarters is going to affect rising cases in Honduras. Many people believe like Honduras, since it doesn't have very readily available testing, that there's more cases there than are actually reported. There's a lot of people unable to pay for their health care, so they're not going to the hospital. There's a lot of people not reporting things and kind of silently passing away in their homes. So there is a lot of stuff going in Honduras, and that's why we thought it would be really cool if you could come and talk to us about your experience.
For sure. And thank you again for having me. And all those points that you bring up are very valid. I can't speak too much about the hurricane as I wasn't in Honduras when the last one happened. However, it is really tragic and definitely it's an under-resourced country in many aspects. So of course that puts them at a disadvantage of having a natural disaster on top of dealing with COVID, and kind of what you were saying about people who get displaced, and then where are they going to go, and are there areas where they can be socially distanced. And basically what I have been reading as well is that most likely they are predicting that cases of COVID will rise, unfortunately.
So Camille has a presentation for us about her time in Honduras, and so we will listen to that.
Sure. So I'll get started here. So I was in Tegucigalpa, which is the capital of Honduras. MSF started working in Honduras back in 1974. They have a strong history working with Central American migration, sexual violence, mental health, and maternal health care. And currently, MSF runs two projects in Honduras, one in Tegucigalpa, which is which is like the regular project. And they've been there for quite a few years, working with women of sexual violence, or women and men of sexual violence, I should say. And it has a very strong mental health component. And then the other project is in Choloma, which is a little bit more in the northeastern part of the country. It's near the second biggest city, which is San Pedro Sula. And that project is focused on maternal health care. The context, well, basically context and demographics of the country, just real quick. So there's 8.1 million people living in Honduras, and it's a rapidly growing population. Between 1990 and 2015, the population has grown by 64, almost 65%. So that really shows you the large amount of population growth, but also the resources that you're going to need to deal with that population growth. Tegucigalpa is a city of about 1 million people. The national language is, of course, Spanish. There is dual public and private healthcare systems. However, it is difficult to get private healthcare. And although public healthcare does exist, it is very much centered in the big cities. And the rural population can have quite a difficult time trying to access it. Even people in the city, if the healthcare system is overwhelmed, they don't really have the capacity to grow at a quick pace. So I think MSF was looking at that when they decided to do an intervention in Honduras for COVID. There's a very high income disparity in Honduras. The Gini coefficient is 0.54 in 2013. In 2012, 1 out of 5 Hondurans lived on less than $1.90 US a day. And in 2013, 65% of households were living below the poverty line, and 43% in extreme poverty. So it gives you a little bit of an idea of the context that we're dealing with, and as well as security. And while you're working with MSF, they take security very, very seriously. So we didn't have, while I was there, I didn't have much freedom to just go out freely, but also because Honduras actually had very strict precautions in place due to COVID, our movements were, I think, even more limited. Basically, everything was closed in the city, and you got to go do your errands and go grocery shopping one day every 2 weeks. And that was dependent on the last number of your passport was the day that you got to go out and do your errands and go shopping.
Very organized.
Very organized, yes. Much more restricted than it's been here. I have a picture here, and this is on one of the main highways, actually really close to where we're working, and just showing a little bit of the political context. So there were protests, there were demonstrations in the streets. Some of it was about people protesting against the corruption of the government. And I have another slide here, which is saying they've painted on the main highway, Donde está el dinero, Honduras lo exige, which basically translates to where is the money, Honduras, we demand to know. So there definitely was a community, like a bit of an uprising in regards to corruption that they believe.
Yeah,
The
I
government.
I heard a thing about that actually, that was a reference to their government spending somewhere around like 48 million for these triage units and none of them being put up. And so people were upset that the government's using COVID as an excuse to like put this money somewhere but not see any results.
Yeah, and I can't comment exactly as to where the money would have gone, but I do know that there were people who were upset about the government handling of the situation. But I think almost in every country right now, I think there's definitely citizens who are upset about the handling of the COVID situation and where the resources are going to. So I have a slide here on the number of cases in Honduras. So this is taken from November 10th from the WHO, and Honduras has just passed 100,000 cases in Honduras, and deaths are 2,751 as of about a week ago. As you mentioned at the beginning, Danielle, the testing capabilities were severely limited at the beginning. Actually, there was a statistics as of April. At the end of April, there was 802 cases of COVID identified, but out of that, 26% were hospitalized and 5% in ICU. So that shows that most likely there was way more cases out in the community that weren't tested. Initially, it was limited testing, and it could take 1 to 2 weeks for test results to come back, which of course causes a huge problem for contact tracing. There's also a problem with the testers getting sick at the beginning, and I'm not sure if this was due to insufficient PPE or if it was due to not proper use of PPE. But that caused a big lag in the number of cases that were identified. So I'm going to talk a little bit about how I got to Honduras. So March 15th, right at the beginning, Honduras closed all of its land, air, and sea borders. I ended up flying to Mexico City, which is the MSF coordination headquarters for that area. So I flew to Mexico City at the beginning of June and ended up having to quarantine there. And I don't think that was the rules from Mexico, but it was the rules from MSF. Basically, anywhere you're going with MSF at this point in time, you're going to be quarantining. So, and the quarantine period was basically just until they could get me to Honduras. And we didn't really know when that was. We needed to get approval to enter the country, and we also needed to get a way to get into the country. So all the commercial flights were banned. So I didn't have much to do there in Mexico City quarantining. I did end up breaking my quarantine briefly. I don't know if you recall, but back in June, there was a big earthquake. I think it was a 7.9 earthquake.
Yeah, I heard about that.
Yeah, so had to run out of my hotel building.
Oh
Broke my
my.
quarantine for a little bit.
Well, at least that's a sufficient reason.
Yeah. Actually, I had another team member scared that I wasn't going to leave, and she's like, "We need to contact her and make sure she gets out of the hotel." So, anyway, after I think I was in Mexico City for 12 days, we did get approval to enter Honduras, and MSF had to arrange a private flight to get us in, which is quite luxurious for, I think, MSF standards. Normally with MSF, you're definitely traveling economy class. So this was a bit of a treat as into how we were entering. And once I got into Tegucigalpa, though, I had to quarantine again. So I had another 2-week quarantine period where I brushed up on all the MSF protocols and learned Spanish, well, tried to brush up on my Spanish. I had like a beginner level of Spanish going into this, could definitely get around as a tourist, but was quite nervous about managing a project.
Yeah, I just had a question about that. So it's like, was there a heavy emphasis from like maybe the upper levels that, you should get on that? Was this like a of your own volition kind of thing? Because
A little bit of both. I definitely wanted to learn more. And when I took the job, actually, originally, I didn't think that I could take the contract actually when it was offered to me. MSF wanted somebody who was fluent in Spanish. And so I let them know that that is definitely not what my level of Spanish is at. But they told me that they would be giving me Spanish lessons and a possibility of a translator as well. And so with that information, I was like, okay, 100% I'm in, and let's do this.
So did you get that translator?
I will get to that in a bit. A good question. All right, so what did we end up doing in Honduras? So the question is, were we going to do testing, contact tracing, or treatment? MSF was well aware, that there was going to be a lack of testing capabilities, but they're also aware that people were going to get COVID regardless if we had more testing capabilities or not. And since we knew that the healthcare system was most likely going to be overwhelmed from what we're seeing in other countries, MSF decided to start up an inpatient treatment center at a low level of patient acuity. So I have a picture here of the project of where I was working. And this building is called the Polideportivo. It was the sports facility of the National Autonomous University of Honduras. So we were working inside this building. If you're looking at the picture on the left-hand side was the MSF side. On the right-hand side was actually a government-run section that had also set up a lower acuity level of patient care. The project was set up based on two main principles, so as to limit droplet spread between people. So this was supposed to be done by making sure that there's 1.5 meters between beds, that we had appropriate PPE, and that we wanted to make sure that the patients and the staff were following proper behavior guidelines to reduce transmission. The second principle was to mitigate contact transmission. So this was supposed to be done by making sure we had good personal hygiene, frequent hand washing, and environmental hygiene, which refers to frequent cleaning. As you can notice here from these two principles, there's nothing about aerosolization of the virus. And this was, again, when this project was designed, it was probably back in about April, May. And trying to, at the time, really was from the WHO guidelines that this was a virus spread by droplets. And so there was no focus on trying to protect aerosolization of the virus. So we did not wear N95 masks, and we didn't perform any procedures that would have been highly aerosolized. So I'll get a little bit more into that later.
I'm also curious, like, what was the initial collaboration with like the government of the region? Like you mentioned how like in one section there's the government run area, and then you've got the MSF area. Did MSF coordinate a lot with the Honduran government?
Yeah, that's a good question. I wasn't there at the initial setup of the project. So I arrived basically about a week. I arrived right when actually we got our first patients, but then I had to do a 2-week quarantine period. So MSF, one of their principles that they pride themselves on is being independent. However, MSF very much knows that we have to work in coordination with local government or municipalities and to have a good relationship. And that was really, really important in this context. as I said, we had a low level of acuity. So if we had patients who were needing referrals, we would need to refer them to a higher level of care. So we had to have a good working relationship with the public hospitals. And in terms of the other section of the Polideportivo, where the government section was, it was very separate in terms of we didn't have breaks together, we didn't share staff. It was very, very separate, but at the same time, we had a very friendly and good working relationship. So our ward that we set up had 20 beds. Initially, it was supposed to be 10 male and 10 female beds. We ended up changing that quite quickly as we realized that we had more male patients than females. And that I think kind of goes with the worldwide trends as well, that we're seeing more hospitalized male patients than female patients. So we ended up making 12 male beds and 8 female. We did have a screening and triage area, and that area was shared with the government section as patients came in, just to make sure that they did meet our criteria, which I'll go through a little bit more. And then we had to make sure that it was a closed site and it needed to be identified as biohazardous. And again, because we were working at the same location as the government hospital, it did actually benefit us here, because this, I think, was already set up. There was strict security. There was security guards outside, including military, that were outside the building 24/7. And entrance was very, very much restricted. So no family, no friends, no visitors could come in. It was just the workers, and you had to be identified properly in order to enter the building. And then in terms of the staff on the ward, so for our 20 patients, we would have 2 doctors on staff, 2 registered nurses, and then we'd have 4 what they called nursing assistants, but they were probably a bit more like licensed practical nurses, what we're used to. They could perform almost all the same procedures as the nurses, as the registered nurses, or at least under the guidance of a registered nurse. All right, so a little bit about what I was doing there and what exactly my role was. So I was the emergency nursing activity manager. So that means that I was in charge of all the nursing related activities. I had a staff of about 35 nurses in total. And that, again, that includes the registered nurses and the nursing assistants. So very, very broad in terms of what exactly does a nursing activity manager do with MSF. Because we do a lot, and I'm sure any nursing activity manager will tell you the same thing, and it probably, there's no way that I can cover it all here in our presentation, but we have to oversee the use and administration of medications, making sure it's done correctly, making sure all of our nursing procedures, our documents and data management tools are up to date. And this is really important with MSF, because you do want to be tracking your cases. In many cases, there is an epidemiologist. In many projects with MSF, there is an epidemiologist to make sure that we are tracking data correctly. Of course, monitoring adherence to hygiene procedures. And this was really, really important in this context. And I'll come back to that in another slide. Training, supervising, and managing all the nursing staff, doing recruitment, job positions, capacity building, and staff evaluations, and making sure that our rosters are up to date. So yeah, so I think it's always a little bit odd being called like a nursing manager. Well, not odd necessarily, because you are doing management activities, but you're also helping to educate. You are on the wards. You are trying to help with the patient care as well. But I think for me, one of the things that I wasn't aware of working with MSF is that I was going to be in a management role, and not for this project, but for my first project. I had training days with MSF in Germany, and they kind of threw this on you that, oh, you're going to be a manager. So I think, yeah, coming from a healthcare background, I think a lot of people working for MSF are kind of thrown off by that.
Yeah, no kidding. There's no really like nursing management course at the U of A, was there?
Yeah.
Definitely not in my undergrad, no.
Yeah. And could you also like touch a little bit more on like the diversity of your team? Because people just always assume that it's strictly maybe doctors are just always on the field, but you've already mentioned, epidemiologists and a nurse leading the way, and the logistics of planning. So maybe you could just touch on like the diversity of your team?
Yeah, definitely. Definitely. It's a really good point. So yeah, lots of times, like you're saying, people just kind of think Without Borders are doctors. Maybe some people think nurses. We definitely have those, but there's so many more people that you need to make this all function. So I would definitely say human resources is a really big part of it, especially trying to put together like an emergency mission like this. You need staff in order to make this all run. So the way that MSF runs in most of their projects is that the expat staff are kind of the coordination, the management, and then they hire all local staff as like local nurses, local doctors. And then you're also, of course, there's going to be much more. So there's mental health and health promotion. And this was a strong focus in our project. So we had a health promoter on the ward 6 days a week. We had psychology services. We had support for patients that they could call up a mental health line. It can be quite multidisciplinary as well. You need to work with pharmacy, making sure that you get your drugs sourced, that you have proper supply, proper stock, that things aren't expired. And then you're also always going to have like a logistician in your team. And your logistician kind of is a catch-all phrase for somebody that you turn to for everything that goes wrong. They have a tough job, but it can be anything from like fixing computers, IT, to doing like mechanical work or fixing, who knows, electrical stuff. Really, they're there to help you out in whatever way that you need. But then you're also going to need sometimes like a little bit more focused care technology like biomed. So we had to have biomed technologists for this mission to make sure that our oxygen concentrators were working. Like we didn't have really high technology for this project, but yet you still need biomed, like even for simple things like your oxygen saturation monitor not working because somebody's cleaned it with too much cleaning supply. So you definitely still need a biomed component. And then if you want to look at laboratory, X-ray, there are some projects with MSF that have expat staff running laboratory, like such as in TB projects and such. In this case, we didn't have a lab, and that's something that throws me off a little bit, even though I've come to work in a bit more like under resource context. It's still so second nature for me working in Canada or in the US, always to have lab services and just to draw your basic labs on patients lots of times daily, right? So we didn't have access to that. But that also just makes your clinical skills ever so much more important. We did have X-ray capabilities to refer patients for X-ray, but we didn't have X-ray on site. Then I also want to mention some other team members, such as like the kitchen. You have to think about how you're going to feed your patients. So for us, we outsourced our kitchen. Our meals 3 times a day were brought in. And this is definitely a good way to, I think, reduce the risk of contamination. And what else? Making sure that we were disposing of our waste and biohazard correctly, and making sure that we had drivers. So like there's such a big team, and it seems like a small thing saying the drivers, but without the drivers, we wouldn't have had the staff coming to the hospital to work. Tegucigalpa shut down their public transportation. So most of the nurses and the cleaners and the support staff didn't have their own cars. So the drivers would be going around the city. They worked 24/7, picking up staff and dropping staff off.
Wow, that's amazing.
Yeah, so it really, really takes a big team. I'll talk here briefly about our personal protective equipment. Of course, you have to make sure that you have proper PPE, and making sure that we have proper hand washing areas, and cleaning of reusable PPE. So our face shields, those were reusable. Everything else basically was disposable. But you also want to make sure that you have PPE that was going to keep the staff like somewhat comfortable. We got one order of gowns that were basically just plastic, and you just sweated through them. I mean, the ward on any day was hot. And then if you're wearing a plastic gown for 12 hours, whew, that is not comfortable. So yeah, trying to make sure that we had the PPE and making sure that we're like actually going to be able to get it into the country as well. just in general, like I know I was saying that how infection prevention control was so important in this project. And really, we have to give a big props to our cleaners, but it's also so much training on making sure that the cleaners are following proper cleaning procedures so that there's not cross-contamination. This was really a big part of the project and something that I think the project did really well. So I'm not going to go much into patient treatment, but basically just to say that MSF was up to date using WHO guidelines, but also that it was an evolving context as the treatment for COVID seems to be evolving. So we did have to, keep up to date with what's going on and make sure that what we were using as treatment was evidence-based. Definitely, I'm sure that you guys have heard from friends. I've heard from acquaintances, oh, have you just given your patients some vitamin C and vitamin D? And, I hear that works. So there's a
Hydroxy chloro, whatever it is that the man down south recommends, which is not evidence-based.
Exactly. Is making sure that we are following evidence-based protocols.
And did you see in Canada and the States, you've got these group of skeptics that are doubting the efficacy of things like masks or even the upcoming possibility of a working vaccine? Were there similar feelings like that in Honduras?
From what I saw, I would say it was like a very unified front amongst Hondurans, wearing masks, wearing face shields out in public, even before I think it was mandatory in other places, and really a really strong focus on hand hygiene and washing your hands. The WHO poster on how to wash your hands properly was set up, I think, almost at every business entrance, and you needed to clean your hands with hand sanitizer. You had to not wash your feet, but clean your shoes in a chlorine-based solution. And honestly, from where I didn't hear much from the community against any of these protocols. And people seem to be very compliant. And I think it shows too, as the cases, while I was there, really did drop. And that's not something that MSF accomplished in the community. That's definitely the community themselves that accomplished that. So there was 4 hospitals in Tegucigalpa that referred patients to us. Out of those 4 hospitals, they had a total of 302 beds for COVID patients. And at around the end of June, beginning of July, their hospital were completely full with COVID patients. And I heard stories of patients basically just sitting on chairs, there not being beds available. So MSF would take the lower acuity patients, but at the same time, lots of times the patients did turn into high acuity, or sometimes we thought we were getting a lower acuity patient and they were quite high acuity. We had oxygen concentrators that we used to deliver oxygen. And at times we'd have to connect 2 oxygen concentrators together kind of by a Y connection in order to deliver up to 20 liters of oxygen. And basically, if you're medical, you know that a patient isn't going to be able to last too long on 20 liters of oxygen. Most times they're going to have to get ventilated. And so we did not have ventilation capacities in our facility. So that's when we would refer them to a higher level of care. MSF as well initially wanted to, like I was saying, take lower acuity cases. They didn't want to take cases with chronic health conditions such as kidney disease, TB, HIV, pregnant women, hypertension or diabetes. They also wanted the patients to be basically in the age range of 18 to 59. And then patients were excluded if they had altered level of consciousness or needed assistance to maintain their airway. We realized that we weren't going to be able to stick to this admission criteria that we wanted, because basically most of the patients that we saw who needed admission did have a chronic health condition. And that's kind of the ever-changing scenario that we're seeing around the world of more and more developing countries having more chronic health conditions, non-communicable diseases. And so that's something that I think MSF is in the midst of adapting to. And we definitely had to adapt to this as well. So I'd say most of our patients had like hypertension or diabetes or both. We definitely ended up admitting patients that were greater than 60, because this is a highly vulnerable age group. So they have less social resources, they have poor health conditions, and that's just pretty normal. As you get older, you're going to have poor health conditions. And so this was, yeah, we had to adapt our admission criteria, like I said.
So who was in charge of deciding whether that patient was admitted or not?
So originally it was the medical coordinator. And then it later on, this got switched to the doctor, who is called the medical activity manager, could make the decision, or the decision could be made according to the doctor in charge for the day on the shift. This really did take up a lot of the doctor's time deciding who could be admitted and who couldn't. There's just a lot of phone calls with the other hospitals and making sure that everything was in order, making sure that these patients that were coming to us, did have their lab work done. We also had another criteria, which was we had to accept patients that didn't have a positive COVID test. So quite a few of our patients ended up just being suspected positives because the test wasn't done.
Oh, interesting.
Right. So then we also, like, just for that fact alone, really, really needed to stress our infection control and making sure that we weren't cross-contaminating between patients, just in case we had somebody on our ward who wasn't actually a COVID case, maybe was a really bad COPD, and you don't want to make the situation worse than what it is. We did have planning for palliative care, but luckily we never actually had to implement it. So this was really quite a relief for me. We were able to make all of our referrals in a timely manner. And then some of our successes. So at the end of the project, in total, we had 139 patients admitted to the hospital. Of those, about 81% were discharged home. 17% needed referral to a higher level of care. And then, so you're probably asking what happened to the other 2%. There were 2 patients who left against medical advice. And then there were a few patients that were referred to a lower level of care. And this is just for patients that needed a little bit longer time to isolate if they were still contagious and they couldn't go home to their families due to social distancing within their home. We didn't have any deaths, which, like I said, big success for our project, and also so glad that it worked out that we were able to refer our patients to higher levels of care. And then we also did have initiatives to send patients to post-respiratory therapy and to send them to appropriate referrals, whether it be like an endocrinologist or follow up like for CT scan. And that was through the government that they did provide CT scans for the patients. And then, like I said, we were able to close the project after 3.5 months. So the project closed at the very end of September 28th. It closed because there was no longer really a need for MSF to be running the project. By the end of August, cases had really, really dipped down. And the local hospitals as well, the public hospitals, were not seeing many COVID cases. So I'll talk a little bit about our challenges that we saw, and some of it I already mentioned, chronic health conditions and how that's affecting the way that we are delivering care. But it also means that we have to be able to make sure that we have all the appropriate medications to treat our patients who are coming in as inpatients. Like I said, they're not just going to need the regular medications that you use to treat COVID, to treat the symptoms of COVID, I should say. But we have to treat their chronic health problems as well. And that was a bit of an issue for MSF at points where we didn't have the correct medication, and we would have to ask the patient or the family to try to source the medication and bring it to us. And so really making sure that we have the appropriate medications and making sure that we have the appropriate resources. Like I said, not having a lab, or not having things like an incentive spirometer, which patients can use to help increase their lung capacity. Something that was kind of personal for me was the language barrier. I have written down here like anti-colonial consciousness. For me, Spanish, I did struggle with it there, trying to manage a team. Like I said, I could get by in a tourist setting with my Spanish, but trying to manage a team when I didn't speak the language seemed really, really difficult for me. And Kristen, to come back to your question from the beginning about did I get a translator? The answer is no. um, one of the points was who they were, I think, were quite skeptic. MSF was skeptic about how are they going to get an MSF translator who wanted to be working in a COVID ward all day. And then also there was, I think, a bit of a pressure for me to improve my Spanish, and they're like, you're not going to improve your Spanish if you have a translator. I think the option was still there if I had really pressed the point to get a translator, which I didn't do, and I did want to learn the language. But it did make me feel a bit guilty to come from a foreign country to be in charge of 35 nurses and not being able to communicate properly with them. So, and I think that also at the time, or just, right now in our world, how some of the social movements are being brought up about expats going into foreign countries and kind of, being in charge, and what exactly is our role? Do the expats need to be there, or can local staff be performing the same role? And I think this is something that I thought a lot about during my time there.
Yeah, I was gonna ask. You mentioned like forgot the title. Was it the doctor, the medical manager, coordinator who was in charge of determining the cases that MSF could take on? Were they locally recruited, or were they expat?
It was an expat. Yeah. So actually all the expat staff were from Spanish speaking countries besides myself. So the medical coordinator was from Mexico, our project coordinator was from Colombia, and actually the medical activity manager, which was the same position as me, but in charge of the doctors. Originally, she was from Mexico, and then the position changed hands over to somebody who was from Honduras. So yeah, I think maybe part of it was the fact that I was the only non-fluent Spanish speaker in the project, and that obviously it made it much more difficult for me to communicate with my team. Another challenge that I had was having nurses being left out of clinical decision making. The culture in Honduras is still very much focused on having doctors make the decisions and nurses going along with it. And I think, well, definitely in other parts of the world, this has changed, where nurses speak up, nurses are critical thinkers. And this is something that I wanted to work on with the nurses, but at the same time, I did kind of think, well, what exactly is my goal here? Is my goal to change the local Honduran medical culture, or is the goal to provide the best care that we can to the patients? So this is something that I kind of put on the back burner, although I think in some aspects, maybe I could have put a bit more emphasis on as well. Because of course, if you do have nurses who are speaking up, if you do have nurses that are using their critical thinking skills, that is, of course, going to benefit the patients in the long run. And finally, my last challenge that I have was staff retainment. And this was due to illness, stigma, and working conditions. We did have some staff get sick. I would not say that it was a large majority at all, but some staff did come down with COVID. The staff, I think almost all the staff that did come down with COVID did work at least as the nurses, worked at another public hospital. And, you can never say exactly where you got it or who you got it from. I think our project liked to think that we had proper infection prevention procedures in place, but it was definitely something that affected the project, especially at the beginning, making sure that we had enough staff and had enough staff that wasn't sick, because when somebody got sick, they were off for 10 to 14 days. The stigma of working with COVID patients, I think this was a concern for some of the nurses, for some of the doctors, a lot of times in Honduras and in Latino families. There's intergenerations living together. And so, you don't want to be bringing home sickness to your grandmother, your grandfather. And then the working conditions, despite I think MSF did provide really good working conditions, we definitely provided good like nurse to patient care ratio, and same with doctor to patient care ratio. It was still, we were doing 12-hour shifts. You're wearing full PPE during that time. And I can attest that that is a really, really long time to be in your PPE and be really hot. And so this is something that all the staff dealt with.
How long did it take you to get acclimatized to the weather there?
Good question. I have spent a lot of time in tropical countries and definitely enjoy tropical countries and humidity. So for me, it wasn't too bad. But being in the PPE, you really do just like sweat through it in that like humidity and that heat. So I don't think I really ever got accustomed to that, like while you're in the PPE. Yeah.
I remember we have these expat talks once a year. Around this time last year, we had a speaker come from talking about their issues of dealing with Ebola in the Congo, and she showed a picture of like I believe that's the same plastic gowns that you were talking about, and they just had to be layered up in all these like PPE and like 30 plus Central African weather. So I can just imagine that it's
Oh,
not fun.
yeah.
Anyway, yeah.
No, it's not fun. And fans were not allowed. We were not allowed to have fans in the unit because you don't want to be spreading virus. You can't have air conditioning. But one of the good things is that the upper part of the structure that we were in was actually open to air, like from the outside. So I think that was a really good design of the project too, for trying to keep down transmission of the virus to staff.
Going back a little bit to the conversation on like that mental battle between trying to influence shift in culture versus coming to do the job you were meant to do. I wondered like how have you dealt with that throughout your career? Because you've mentioned that you've obviously been placed in places like West Africa and Nigeria. So like there's obviously lots of different cultural values and like a culture shock, I guess, from like practices in Canada and the West versus like going there. So like how have you usually like balanced those tensions?
I think that's a really good question. I think it's something that I'm still
Mm.
working on, honestly. I think a lot of it is once you find like a trusted member of the team, whether it be like a local like nursing supervisor, which is I had a local nursing supervisor in Nigeria who I really, really trusted and could just ask him what is normal, what is not normal, what should I expect, and what do you think that we could improve on. So that's part of it. Part of it though is really like looking into things myself though too, because it's like there needs to be a balance of yes, let's try to change some things that are going to make things better, but we can't change everything to make it be the same as what I'm used to back home. Even working in Australia, I remember when I started working there, I think on a daily basis, I would say, well, in Canada, we do this. Well, in Canada, we do that, whether it be putting in a large bore like intravenous into somebody or yeah, just doing a different type of like nursing procedure. And I think I had to learn there to stop saying that and to realize that I was in a different country and to adapt to their practices. So I think there has to be a balance between, making sure that we are providing the best type of care, but also not necessarily changing the
The
culture.
culture, yeah, no, yeah, it's tricky. I get that because it kind of goes back to that point of the anti-colonial sentiment that we're sharing, like trying to dismantle this notion that maybe it's the West coming in here trying to be the savior once again. That you don't want to like project that complex, right? But at the same time, if you feel that you're seeing an injustice, you also want to feel like you want to do your best to change that and restore justice. So.
And I think as a manager, one of the things that I've learned is a good way to try to bring about some of the changes is not necessarily to enforce them yourself, but to ask the staff, what do you guys think that we could improve on? And they definitely have ideas for sure. But I think it comes across better if ideas are coming forth from the local staff and not from an expat coming in and saying, this is how we are going to do things, like bottom line.
Hmm. Um, so walk us through like an average day, what kind of things you would see, what it would look like to be, what your like sleeping accommodations were like and such.
Was quite lucky in this context, actually, that we had really nice accommodation. It was probably most likely the fact that we had nice accommodation was due to the security context and making sure that we had to be kind of like in a safe zone of the city. Even though I didn't feel unsafe at all, what I saw in Honduras, I know that there still is high rates of crime in some areas. So we were in a very safe area of Tegucigalpa and had very nice living conditions. And I was, at first, I was quarantined by myself in an apartment. And then later I moved in with the human resources coordinator who was actually from Honduras. And so I had one roommate. I think I arrived at work, I'd get up, do my exercises, arrive at work at 9 o'clock. And oh yeah, it was, or maybe it was 8 o'clock. I think actually we arrived at 8. So I got up quite early.
That hour difference makes
I know, doesn't
it does wonders.
And it would get hot really, really early. But inside of the building, there, it was a bit cooler in the mornings, and that's usually when I would put on all my PPE, go into the ward, and start doing the roundings with the nurses and the doctors, checking in on our patients, seeing what needed to be done. And there's almost always a list of things that nurses needed, or something that was broken, or they're giving me a list of something that needed to be fixed. So I'd spend a couple hours usually in the morning in the ward itself and with the patients, and then also looking at if we needed to get patients ready for discharges or for referrals, and making sure we had all those things in order. I spent a lot of time as well doing the rosters for the nurses, which doesn't sound all that exciting, but most of the nurses had another job on top of this one. So trying to coordinate that and coordinate all their shift changes actually took up quite a bit of my time. In the afternoon, lots of times I would try to work on some type of nursing education, putting like another like protocol in place or a flow chart so things were easier to read or easier to follow for the nurses. And then also working quite closely with the medical activity manager, the doctor, and making sure that the nurses and the doctors were kind of on the same page about things, making sure that we were all like following the same protocols, and it's not the doctors doing one thing and the nurses doing something else. So we worked together quite closely. I left work about an hour early or so because I had a 2-hour Spanish lesson every like late afternoon. So I'd go home to do a Spanish lesson, and I think I finished that around 6:30. And most of the times I'd have my evenings free, but couldn't really go anywhere. So my evenings were really spent in my house.
Oh, wow. That is just incredible dedication, honestly, for you to be continuing your Spanish education while you're still there every single night. And
2 hours too.
Yeah, 2
Uh,
hours, 2 hours. My Spanish teacher told me that I was crazy, but
I can't even get through a 30-minute online school lecture.
yeah,
So
I was gonna
yeah.
say.
and yeah, usually it was like 2 hours of Spanish. And then after that, I was responding to text messages from the nurses. And thank goodness for WhatsApp, in all honesty, because I would use WhatsApp for all my communication with the nurses and like translate messages.
Oh,
So
is there a translator on WhatsApp?
no, but I just Google translated and then.
Oh, okay.
But I'm saying,
Yeah.
like, thank goodness that we have
Yeah.
this technology now. Like,
Mhm.
if it
Yeah.
had been 10 years ago, 15 years ago, like, it would have been much more difficult for me to do this job, I think, or else I definitely would have needed a translator. I don't know.
So when these projects are done and wrapped up from your role as nurse activity manager, is that it for you then? You just kind of like get to fly back home and, reflect, or does MSF require just a bit more of you in terms of like writing a debrief or analysis?
Yeah, exactly. So you always have a debriefing to do, or multiple debriefings to do with MSF. So at the end of the project, you kind of write a wrap up report of everything that's gone on. And then, but you have debriefings with almost all the different sections within MSF. So whether it be and so I had debriefings in Mexico with the coordination team. So there's like medical coordination, of course, there's the HR, pharmacy that I debriefed with. And then I'd also have debriefings with my HR manager in Canada.
Can you talk a little bit about how you were kind of dealing with like your mental health when you were there as well? I can only imagine that it's extremely stressful. And I mean, we all know that even just quarantining here back at home, it's not always great to not be doing anything all the time. And so, what did you see in your staff that you wished you could help them with? And what were you doing to like help motivate your staff and motivate yourself as well?
Yeah, good question. In terms of my staff, I think that the staff were, most of them were quite motivated to work. This was definitely like an opportunity for them to make some extra money. Some of it was, for some people, it was extra if they had another job. Some people, this was a contract where they were just, trying to work as many hours as possible, because MSF does provide usually a bit of a better salary than the government, the local government does. We did have mental health counselors or mental health line available to all of our staff, to the nurses, the doctors, the cleaners, everyone. And it did on occasion, did suggest that some people would use it or benefit from it. And people were very open there, I would say, to talking about mental health and talking about their stressors. So it wasn't like really closed in or bottled in. But then again, like for me, with the language barrier, it was, I think, a bit more difficult to have like a relationship like that where people would come to me and tell me these things. I did get to that point a bit with a few of my staff members, but probably not as much had I been obviously being able to communicate fluently. As for myself, I think exercise is kind of one of the things that keeps me sane. So even though I couldn't, go to the gym or go out for runs, I would exercise just like right in front of my house, and try to do that almost every single morning. And then I think also like when I was living on my own, because I was in my own apartment for about a month, I think I've kind of gotten okay at adapting to just being by myself, and it doesn't like bother me too much. I'm sure, like compared to some people. But however, like once I did move houses and I had a roommate, it was so nice having somebody to talk to. So I think that really helped out.
Okay. Anything else from you, Christian?
I was gonna, yeah, maybe ask a less serious one, but in your free time, I know on this side of the Atlantic, when quarantine hit, a lot of people got into baking banana bread. I don't know why that's a thing, or just baking in general, but wonder if you ever, tried cooking anything as well, fun, or like a native dish from Honduras. And
I did while I was in quarantine, actually. So I really, really like pupusas. And I always thought that it was native to El Salvador. I visited El Salvador in the past and I absolutely love pupusas. They're kind of like thick tortillas with stuffed inside with like usually like beans and cheese or pork or some type of meat. And they're absolutely delicious. And then when I got to Honduras, I'm sitting there in my quarantine and going through my like delivery apps and see that they have pupusas there as well. I mean, they're neighboring countries, so why wouldn't they, right? So I was like, oh, okay. So I ordered myself some, and they're really good. But then I'm like, okay, well, I have all this time. I'm gonna try to make my own. And it is much, much harder than what I thought. I think it took me like six,
yeah.
7 hours trying to like stuff my pupusas, and without all the filling coming out, it was way harder than I thought. And so from now on, I'm like, whenever I'm at like some pupuseria, tip your pupusa ladies, people. That stuff takes work.
Advice for everyone. Thank you.
There you go. Thank you.
Yes.
So, as we're closing in here, do you have any last piece of advice for anyone who wants to work for MSF like you? I know you said that there is a lot of experience required and was more than you had suspected.
Yeah.
So,
I mean, definitely. I think like if it's really like one of your goals, go for it. It's definitely needed. There's a big need for medical workers, and not just medical, like I said, logisticians or HR. Um, but yeah, I think it's definitely like look at the recruitment pages for MSF and see what they require for the type of job that you're looking for. Like for nursing, I can speak to specifically, MSF really wants you to have a diploma in a tropical nursing course. They really want you to speak French if possible. I actually don't speak French, but I'm still here, so it is possible. And they really want you to have management experience. And so I think that's like the three big things. And I think you're going to get that. So it doesn't necessarily mean that you needed to be like a manager of nurses. Of course, it's going to help if you are. But if you even have like leadership experience in different areas, to kind of like follow those routes, because that is something that MSF is looking for.
okay, so we're coming up on the hour mark here. So thank you so much for sharing your experience with us, Camille. I feel like I've learned a lot, and I personally am very inspired. I've always wanted to work for MSF in some sort of way, but I'm glad I get to have a little bit of insight on the kind of dedication it takes. So thank you for your time. As for the rest of the speaker series, Christian, how many more do you think we're gonna do?
Really, it's honestly always up to the availabilities of the speakers we can find, but we're hoping to get more professionals, whether they be from nonprofit organizations like MSF, I want to say Friends of MSF, or public health experts in AHS or leaders in the U Alberta community. So yeah.
So if anyone ever has a suggestion for someone to bring on, then we're always open to suggestions. But as for now, we'll close up this first episode here. Thank you again so much, Camille.
Yeah. Thank you, Camille.
Thank
All
you.
right.